Okay, so this is a continuation of the autonomic nervous system. In this module, we're going to spend some time talking about the parasympathetic system. We spoke about the sympathetic system in the last module. I mean, we'll end up talking about both of them because they're so related. And we're also going to talk about certain disease states of the that involves some of these systems and treatments of them. And as well, we're going to introduce the neuromuscular junction, which are your skeletal muscles, the muscles you use to move, right? So the neuromuscular junction is voluntary. It's under voluntary control. You decide when you want to move your arm or your leg or smile. So we're going to talk about the neuromuscular junction as well. And just keep in mind these receptors, and I keep on reminding you, especially in the autonomic nervous system, that it's all about the receptors that then stimulate the organs where the receptors are. So in the sympathetic system, where were those receptors? The alpha 1, mainly on the blood vessels, remember? And a bit in the prostate. The alpha 2, well, that was that unusual one that's in the brainstem. And we don't have many drugs for that one. Where was beta 1? Well, that was basically on the heart. Where's beta 2? Well, that's essentially in the lung, a bit in the blood vessels, and you have some beta receptors in the kidney and on the uterus. And of course, you can have sympathetic receptors in other parts, such as the gastrointestinal tract, in your eyes. So just know a bit about where these receptors have been scattered, and that will tell you what, when introduced with epinephrine, when given epinephrine or norepinephrine, what would you expect to happen? Okay, and it's going to be the same for the parasympathetic. Except I think the parasympathetic is a slightly easier because there's less types of receptors. I think it's just a bit more straightforward. Okay, but I will bring up the sympathetic system again while we're talking about the parasympathetic system, just so you have a good idea of the back and forth that they do to control the autonomic systems of your body. So systems in your body that really don't want the conscious mind to get involved with. It's the system that wants to maintain homeostasis without you directly getting involved. Okay? Okay, so this second slide, life's a balancing act, that definitely applies to the autonomic nervous system of the back and forth between the sympathetic and parasympathetic system that are constantly adjusting your many of your vital signs, many of the parameters that you're just not aware of from second to second, such as your heart rate, your blood pressure, how dilated your pupils are, what your digestive tract is doing, all those things that it's taking care of as the autonomic nervous system. I will review the autonomic nervous system in this module again. I know we did it in the last module, so you can skip the slide if you want to. We'll go over some prototype drugs for the parasympathetic system. And remember, the parasympathetic system, you can stimulate it, so it's an agonist, or a parasympathomimetic, so it mimics the parasympathetic system, or you can antagonize it, meaning you can block it, and that's a parasympatholytic or an anticholinergic, because the parasympathetic system is the cholinergic system. It runs on acetylcholine as the neurotransmitter, so we call it also the cholinergic system. And we'll start to know some side effects of some of the drugs that are used in the autonomic nervous system and the parasympathetic system. Okay. Now, I just want to tell you, I am going to purposely repeat myself with some of these slides because this takes a bit of repetition. It's not like you need to know every detail of these systems and every nerve, but a basic understanding of what you would expect to happen if the sympathetic system was stimulated or inhibited, or if the parasympathetic system was stimulated or inhibited, is important. And that's where some knowledge about the drugs will come in, because the first thing you should ask yourself is, what is this drug? Is it a sympathetic stimulator? Is it a sympathetic inhibitor? Is it a parasympathetic stimulator? Or is it a parasympathetic inhibitor? And that'll just come with a bit of time, okay? And once you know what it is, then you can definitely predict the action of the drug and the side effects of the drug, okay? And we'll do some examples of that as well. So it'll come with time. Okay, so this slide we've already done in the previous module. I'm just going to talk about it for a couple of minutes. So on the left-hand side, we're talking about central nervous system, brain, spinal cord. That's your central nervous system. Okay. Sometimes people don't think of the spinal cord as part of your central nervous system, but it's actually just an extension of the brain. So it's included in the central nervous system. And really, what's receiving all the impulses coming from the periphery is your central nervous system, your spinal cord, and your brain, right? So it's getting sensory input, and it's sending out neuronal control to the body through peripheral nerves, right? So motor processes. So on the other side is the peripheral nervous system. So these are nerves that are going to carry the information from the CNS to the rest of the body, right? So they can be motor nerves, sending signals to your skeletal muscles, to glands. You decide to start walking. Well, those are skeletal muscles that are innervated by motor nerves to start the contractions of the muscles. And then there's the sensory division that's just sending information, sensory nerves, back to the brain. So whether it's sensation of something hot on your skin, or the sensation of balance, or something that you're stepping on, you have all kinds of sensory nerves that are being sent back to the brain to give information, right? And that's essentially why can you stand up with your feet together and your eyes closed? Well, your brain is constantly getting sensation back, and that particular one is called proprioception, where it's telling the brain where you are in space. You always know where your hands are, you always know where your feet are, and that's proprioception, the awareness of where your body is in space. So different sensory divisions. Okay, and then so the somatic nervous system is basically the control, your voluntary control of your body, okay? Versus the autonomic nervous system, which is what we're talking about. And it's the control of all those involuntary systems that your body wants to do irrespective of your voluntary input. So heart rate, respiratory rate, blood pressure, secretion of glands into in the digestive tract, bowel, uterus to a certain extent, bladder, all those, okay? And then that's of course broken up into the sympathetic and the parasympathetic division, which is what we've been talking about. The sympathetic division has adrenergic receptors, sympathetic receptors, and they're broken up into alpha and beta, and it all depends on where these receptors have been scattered in different parts of your body, which will elicit the sympathetic response. And on the other side, the parasympathetic division, it's also called the cholinergic system because it has cholinergic receptors. They are receptors that acetylcholine stimulates, and that's why it's called cholinergic. And the receptors, and we'll come to this, there's two types of receptors, but the main one in the parasympathetic system is muscarinic receptors. Okay, so if you were to ask, what kind of parasympathetic receptors do I have on my heart? Muscarinic. In my gastrointestinal tract, muscarinic. So when the parasympathetic system is when the nerve is going to the organ, it's acetylcholine that's released, and it's almost always a muscarinic receptor. Now, the one thing I want you to remember is that these two, so sympathetic and parasympathetic, are a two-nerve system. So there's one nerve that leaves either the brain or the spinal cord, and it communicates with the second nerve, and it's the second nerve that actually goes to the organ that is going to affect, okay? And so that'll come into, we'll discuss that on a different slide. And typically when we're talking about the two nerve system, there'll be terms that you'll come across, such as ganglionic, so the preganglionic nerve or the postganglionic nerve. That just all that's referring to is the two nerves. So the first nerve is the preganglionic nerve, and the synapse between the two nerves is the ganglion, and the nerve after the ganglion is the postganglionic nerve, and that's the one that goes to the organ to be innervated and affected by the system. Okay, so this won't, I'm hoping this won't be confusing after we've gone through those terms a bit more. Okay, for this next diagram, which is a repetition of the last module, just look at the organs that are involved in the two systems. So they're all organs that are under autonomic control, right? Control that you don't need to be involved in. So whether it's how dilated your pupil is, how much secretion your gastrointestinal tract, like your salivary glands, are secreting, how fast or slow your heart is, how fast or slow you're breathing, peristalsis, contractions in your stomach and your gastrointestinal tract, contraction of the gallbladder on the parasympathetic side, stimulation of sugar release from glycogen that's stored in the liver by the sympathetic, So there's slight differences because remember the sympathetic system wants to get you ready for some kind of action. That's why it's releasing glucose from your liver. That's why it's stimulating the adrenal gland to secrete epinephrine and norepinephrine into the bloodstream. That's why it's relaxing the bladder, because it doesn't want you to urinate right now. It wants you to hold it. And that's why it's inhibiting the sexual organs. So there's minor differences, but you'll see that in general they're stimulating and inhibiting. There's a balance with the organs that you're seeing on this slide. Okay. Okay, so we're talking a bit more about the parasympathetic division in this module. So this would be the rest and digest side of the autonomic nervous system. Or I think there's another one called feed and breed, just as a reminder for parasympathetic actions. So it tends to be more active than the sympathetic system under low stress conditions where you're either resting, eating, promotes relaxation, body maintenance, so urination, bowel movements, digestion of food, all those things, okay? Now, so look at some of the slide above showed you which organs have receptors for the parasympathetic and sympathetic. So now look at the effects when you have parasympathetic stimulation. Constriction of pupils stimulates salivation in the mouth to start breaking down food. Slowing the heart rate, bradycardia. Constricts the bronchial tubes, so bronchoconstriction. You don't need as much air going in and out. Stimulates digestion. So when in terms of stimulating digestion, that's going to be secretion of bile from the gallbladder, secretion of digestive enzymes from the pancreas, increased peristalsis and contractions of the small intestine to move the food along, stimulation of the stomach to secrete acid and digestive juices, contraction of the bladder to empty the bladder, and potentially stimulation of the sexual organs for sexual activity. Now, it's not to say that all of these need to be stimulated all at the same time in the parasympathetic system or the sympathetic system. It's that there's potential. So if you had a complete parasympathetic stimulation, these would be the things that you're seeing. Okay? So it doesn't mean that, oh, my pupils constricted, that means I'm going to get all of these things. No, that's not the case. But if you think of it as a whole, it can be helpful because you know when someone says this person is getting parasympathetic stimulation or parasympathetic inhibition, you can immediately go to those organs and think of what could possibly be happening with this organ. Okay, so I won't spend too much time on this slide. Division controls. This is just I think this is on the previous module as well. Just between sympathetic and parasympathetic again. I think you're going to get tired of hearing the word sympathetic and parasympathetic after all this, but that's not necessarily a bad thing because that means you're starting to understand it a bit. I won't spend too much time on this slide, other to remember that this is just a bit of, one can go a bit higher. So the parasympathetic system can be at a higher level, a higher tone, and the sympathetic system stay the same. So now you're getting more parasympathetic activity, and the alternative can happen where the sympathetic system suddenly jumps up because of some kind of perceived threat or an activity, such as going for a long run, something that needs to activate your sympathetic system. So just fine-tuning of all the different organs to maintain homeostasis. Okay, so let's just look at this slide a bit here on parasympathetic and sympathetic systems. And both systems are a two-nerve system. So there's typically one coming from the brain stem, such as in the parasympathetic through one of the cranial nerves. And then that one nerve called the preganglionic nerve goes to a ganglion, and a ganglion is just a meeting of nerves, kind of a cluster of nerves, and that connects to the postganglionic nerve, which is in red here. And we're looking at the top one. And then the postganglionic nerve is going to go to the different organs that the parasympathetic system innervates. Okay, so whether it's the eye or the heart or the blood vessels or the uterus, so it's a two-nerve system. And when we're talking about the parasympathetic system, which is the top line there, we're usually referring to it, the neurotransmitter, as acetylcholine. So you can see at the meeting of the first nerve and the second nerve at the ganglia, that's acetylcholine. Between the postganglionic nerve and the actual organ it's affecting, that's acetylcholine too. So that's why the parasympathetic system is a cholinergic system. Now, if you look at the ganglia, so there's two types of receptors in the parasympathetic system, and one of them is much, much less important than the other. So there's the nicotinic receptor, and that's typically at the ganglia of the parasympathetic system. And you've heard this word before, the muscarinic receptors. And those receptors are by far the most common receptors that are spread throughout the whole parasympathetic system at the postganglionic nerve, where it innervates the organs. So for example, the heart. Well, what receptors are on the heart? Muscarinic parasympathetic receptors. And that's why the parasympathetic system is also called the muscarinic system. So all kinds of terms, they all mean the same thing. Parasympathetic, cholinergic system, muscarinic receptors. That's all the parasympathetic system. As long as you know that it's a two-nerve system, and acetylcholine is the main neurotransmitter, and that there's nicotinic receptors at the ganglion, but all the other ones at the postganglionic, at the organ level, where acetylcholine is stimulating the different organs, are muscarinic. All right, now let's go on to the sympathetic system. And if you look, you'll notice that the sympathetic system is really coming off the spinal cord. Remember that sympathetic chain. It's just a line of ganglion which are part of the sympathetic chain in the thoracolumbar. So where's the parasympathetic come off? Well, it comes off of cranial nerves and from the sacral nerves. Where does the sympathetic system come off? The thoracolumbar sympathetic chain that follows the spinal cord. Okay, and it's a two-nerve system too. So it goes from the spinal cord as a preganglionic nerve to the ganglia, which, by the way, you'll notice they're nicotinic. That's not highly important. And then there's a post-sympathetic nerve, post-ganglionic nerve, that then goes to the different organs. And what do they use? as their neurotransmitter at the organ, at the synapse between the nerve and the organs? Well, norepinephrine, sometimes epinephrine, as you'll see at the bottom there. Dopamine, that's another, it's in the same grouping as catecholamines. So norepinephrine, epinephrine, dopamine. And the one time that it uses acetylcholine is typically at the sweat glands. Okay, so it actually uses acetylcholine at the sweat glands in your skin. The one other slightly different, so I mentioned that it's a two-nerve system, whether it's parasympathetic or sympathetic, because there's a pre and post-ganglionic nerve. The only exception to that is the bottom, where the pre-ganglionic nerve in the sympathetic system goes right to the adrenal gland and stimulates the adrenal gland to release epinephrine and norepinephrine into the bloodstream to then have its effect on different receptors, right? So for the most part, think of norepinephrine as the main sympathetic neurotransmitter. Sometimes it can be dopamine, okay, such as in the kidney. I wouldn't try to necessarily keep that in long-term memory. And sometimes, or not sometimes, but it does use acetylcholine to go to the sweat glands as its neurotransmitter. But in general, it's using norepinephrine as its main neurotransmitter. So if I was to say to you, in the sympathetic system, which organ only has a preganglionic nerve that directly stimulates it? You'd say, oh, that's the adrenal gland. That's the only exception. All the others have two nerve systems, right? So going to the heart and the blood vessels, going to the kidney, because remember the sympathetic system stimulates the kidney to release renin. So all the other ones, and including the parasympathetic system, are two nerve systems. And I wouldn't get too worked up about nicotinic receptors at the ganglion. It's just for you to know that there's two different types of receptors. And by the way, the nicotinic receptors at the ganglia are they're in the sympathetic and parasympathetic chain, right? Or sorry, they're in the parasympathetic and sympathetic system. And we don't really use drugs at this synapse, at the ganglion. It has way too many side effects, and you can see that it would stimulate the parasympathetic and the sympathetic at the same time. So we don't typically use drugs. We use drugs between the second nerve, the post-ganglionic nerve, and the organ. Okay, that's typically where you'll see drugs having their effect. Okay, so just a reminder here, those two different receptors we spoke about. So acetylcholine is the main neurotransmitter of the parasympathetic system. So if you're asked a question, what neurotransmitter does the parasympathetic system use? Acetylcholine. Muscarinic receptors are the main receptors on all the different target organs that then get stimulated by acetylcholine and then have their action. Okay. Nicotinic receptors, we saw in the previous diagram, they're between the pre and the post ganglionic. They're at the synapse there. And the other place that they exist, and we haven't spoken about, is between your neuromuscular junction. Okay, those are nicotinic receptors. And we'll talk about the neuromuscular junction because there's diseases of the neuromuscular junction where the nerves that are stimulating your voluntary muscles, your skeletal muscles. There's diseases of that junction, and there's also drugs that we can use there. Okay, so those are they have nicotinic receptors. Does it really matter that they're nicotinic? No. The neuromuscular junction does use acetylcholine. And the reason why we distinguish between nicotinic is when we were studying these receptors years ago, these particular receptors were stimulated by nicotine, and the other receptors were stimulated by something called muscarine. That's the only difference. So I wouldn't get overly worked up about nicotinic versus muscarinic. And if I was to ask you, what does the parasympathetic system typically function with? Muscarinic receptors. What's the receptor between the two nerves of the parasympathetic or sympathetic system at the ganglion? Those are nicotinic receptors. What's the receptor at the neuromuscular junction of voluntary muscles? That's a nicotinic receptor, and it uses acetylcholine there. Okay. Okay, so let's talk about cholinergic agonists for a bit. So just stop for a minute and think, okay, cholinergic, that's the parasympathetic system, and an agonist. An agonist means it's going to stimulate the parasympathetic system. So what can I expect to see if I have some kind of drug that stimulates the parasympathetic system? And this will explain not only the effect of the drug, but the side effects of the drug. Okay, so my eyes, they're going to become constricted. Okay, so the pupils are going to become smaller. My heart, I'm going to get bradycardia and less contractility. Okay, my lungs, what's going to happen there? I'm going to get a bit of bronchoconstriction. Okay, so if I'm asthmatic or if I have some kind of lung condition, that may not be great, but that's just to keep in mind. In my mouth, I'm going to get more saliva made. I'm going to get increased peristalsis in my intestines, more gastric and intestinal juices. Okay, I'll keep that in mind. I'm going to stimulate my bladder to potentially contract. And let's just leave it at that, and we'll go on to some drugs now. Okay, so do this very mechanically at the beginning in terms of cholinergic agonist, cholinergic antagonist, something that's going to stop the parasympathetic system from working. So do it mechanically at the beginning so that it becomes second nature, and you know, oh, okay, I know this drug stimulates this system. These are the expected side effects and the expected effects of this drug. Okay, so let's get into a drug here called bethanechol. We will, and that's the prototype one. We will get into one of the similar ones called pilocarpine, which is it's an eye drop that we use for glaucoma. But we'll concentrate on bethanechol here. And so what's bethanechol used for? So bethanechol is a parasympathomimetic or a cholinergic agonist, and it's used to stimulate the bladder. Okay, so there's certain conditions where the bladder can become lazy, another word for atonic, or the bladder is not fully emptying itself of all the urine in it, because of some kind of muscle issue, like the detrusor muscle of the bladder isn't fully contracting down to empty the bladder. So bethanechol is a muscarinic agonist. I'm just using different terms here, but they're all the same, right? Parasympathomimetic, cholinergic agonist, and it contracts the detrusor muscles, And it also relaxes the bottom of the bladder where the urethra is, and that's called the trigone, and relaxes the sphincter muscles of the bladder to allow the urine out. Okay, so this will result in increased pressure in the bladder from the contraction, the muscle contraction, and also it'll help pass the urine. Okay, so this drug can be used with someone who has just a lazy bladder, an atonic bladder, just not fully emptying anymore over time. It's become a weakened bladder muscle. Or someone, say, who's post-surgical. So say you've gone for surgery, your day one after surgery, you had anesthetic, and they notice that it's not really urinating very much. Okay, it could be an obstruction. It could be a blockage in the system, say from an enlarged prostate gland, or it's just the anesthetic that has affected the bladder and made it lazy, and it's filling with urine but not really wanting to contract. So you can use this post-surgical to stimulate the bladder contract, as long as you're sure that there's no obstruction like an enlarged prostate, which is the issue. Because you can imagine if you're contracting the bladder against a large prostate, that's just going to bring bladder spasms, but the urine can't get out. Okay, so, and we'll come to that. So really for a lazy bladder, and in particular post-surgical urine retention. So how does it work? Well, we probably should have started with this one, because if you know how it works, then you can predict where it's going to have its action. It's a muscarinic agonist, or a muscarinic stimulator, which makes it a parasympathomimetic, which also makes it a cholinergic agonist. Okay, so what are the side effects of this drug? Well, it's going to be all parasympathetic effects that you didn't want. Increased gastric acid secretion, nausea, vomiting, and abdominal cramps, and diarrhea. Well, you're stimulating the gastrointestinal tract to work, which is one of the functions of the parasympathetic system. Just in this case, there's no food, it's just that you're stimulating the system to work, and you're getting these effects. Sweating and tearing. So tearing, you're producing more secretions. So whether it's tears in your eyes or increased salivation in your mouth, this drug can do that. I know it's not listed. Sweating. Well, sweating can also occur with this drug. And you could ask, well, sweating is a sympathetic thing, right? I mean, you sweat because of sympathetic stimulation to the sweat gland. So why is this drug doing that? Well, if you go back to that slide that we just did a couple of slides ago, you'll see that the sweat glands are innervated, and they use acetylcholine as, remember there was a couple of exceptions. The sweat glands use acetylcholine, and this is a acetylcholine agonist. So you can get sweating with it. Sweat glands in general are innervated by the sympathetic system, but because acetylcholine is there as a real exception in the sympathetic system, this drug stimulates it. What about bradycardia? Sure, it's a cholinergic agonist. It's stimulating, or it's causing the heart to have more parasympathetic effect, and you have bradycardia. Hypotension. You do have some parasympathetic receptors on your blood vessels, not many, but when they're stimulated, you can get hypotensive. And also don't forget you're getting bradycardic, and that can cause hypotension. Bronchoconstriction. You're making those tubes in the lungs narrower. Okay, so those are things to think about. Now let's look at when you shouldn't use these based on these adverse effects. Someone who has urinary obstruction, such as a male with BPH, should not get this drug. You're going to force the bladder to contract against an obstruction, such as a large prostate. So all they're going to get is terrible urinary spasms, but it's not going to get the urine out. What about a gastrointestinal obstruction? Say they have a bowel obstruction and you use this drug. Well, they're going to get more spasms, more pain, but it's not going to relieve the obstruction. So we wouldn't use it in someone with a bowel obstruction because it stimulates the gastrointestinal tract. Peptic ulcer disease. Well, if you look above it, it stimulates gastric acid secretion, which is going to aggravate peptic ulcer disease. Asthma. No, don't use an asthma. It causes bronchoconstriction. So because it's a parasympathetic drug, it'll cause bronchoconstriction, which we would want to avoid in an asthmatic. What about heart failure? Well, it's going to cause bradycardia, and it's going to cause low blood pressure. Those wouldn't be things you'd want to be messing with in someone with heart failure, okay? So you can see that if you know where all the receptors are and you know the actions, you can probably predict the adverse effects and conditions as you get to know them more, contraindications. What about the nursing responsibilities? So the antidote would be atropine. So say you gave someone much too much bethanechol, which is a cholinergic agonist. So it's stimulating all these acetylcholine receptors throughout the body, and they're tearing and they're drooling, and their eyes are really constricted, and they've got diarrhea and vomiting from all this parasympathetic activity. Well, you can give an anticholinergic, so a drug that will block the receptors from bethanechol affecting the receptors, and that prototype drug is atropine. Okay, so atropine will block the receptors, and bethanechol won't be able to stimulate them as much. Okay, typically bethanechol would be given before meals, so an hour before meals or 2 hours after meals. When you want to give a drug and not have food interact with it, you give it an hour before or 2 hours after a meal, because it takes the stomach about 2 hours to empty. Okay, and it would be fine to monitor ins and outs, because what's this drug doing? It's stimulating the bladder to help with urination, but it can also give you diarrhea as a side effect. So input and output would be appropriate with this drug. All right, let's change topics here for a bit. We're going to come back to the parasympathetic and the sympathetic system, but we're going to spend a bit of time on the neuromuscular junction. So muscles of your body, whether they're in your legs or your arms or your face, your tongue, your breathing muscles, the intercostal muscles, the diaphragm, they're dependent on nerves for contractions, right? So the nerve stimulates the muscle contracts. And these are voluntary nerves. You can control them. So there's a condition called myasthenia gravis, where an autoimmune disease, meaning a disease that your body has recognized something in your body as foreign, as an antigen. And in this case, it's recognizing the acetylcholine receptors at the neuromuscular junction as foreign, and it's produced antibodies to destroy these receptors, which is very unusual, right? Can you imagine how you couldn't make up this disease if you wanted to? So an autoimmune disease that attacks receptors up the neuromuscular junction, and it makes it difficult for the neuromuscular junction to function. So what effects are going to happen from this? Well, so all your muscles are now going to be weak because the impulses from the nerves are not getting through. So generalized muscle weakness. let's start with some of the what kind of symptoms can you get? Well, your eyelids will be droopy because your open eyelids are reliant on muscles. So your eyelids will be partially closed, which is a very common symptom in myasthenia gravis, and it's called ptosis, Ptosis. So ptosis of the eyelids. You can have slurring of your speech, difficulty speaking, because that's reliant on the muscles of your face. And speech is reliant on your tongue. So you can have weakness and difficulty swallowing because of all those muscles. Walking can be an issue. Holding something with your hand can be an issue. It can be weak. Lifting your arm can be an issue. So now this can progress, and you can run into the biggest issue of all, which is difficulty ventilating and breathing, because the neuromuscular junction at the muscles of for ventilation, your intercostal muscles and your diaphragm are weakened, or are not working properly because of lack of acetylcholine receptors. So you have the acetylcholine there, you just don't have the receptors for it to act on. So ventilation and breathing is likely the biggest concern with myasthenia gravis. So we've mentioned that the neuromuscular junction operates with acetylcholine, right? So remember, the parasympathetic system operates with acetylcholine, but we're not talking about the parasympathetic system here. We're talking about the neuromuscular junction. So it just so happens to use acetylcholine as well. So how can we treat this? We're going to talk about treatment, and we're going to talk about how do we diagnose it as well. Let's just talk about treatment on this slide a bit. So how can we affect how can we improve the neuromuscular communication again? Well, the first thing that we need to do is these people need to be treated with immunosuppressants, okay, to reduce the immune system from producing these autoantibodies that's destroying the receptors in the first place. Okay, that's one part of the treatment. So immunosuppressants to treat the autoimmune disease to begin with. Okay, what about the neuromuscular junction? What can you do? Well, you could give a cholinergic drug. We just spoke about one called bethanechol, but that was for your bladder. So I could give more acetylcholine since there's fewer acetylcholine receptors. I'll just give lots and lots of acetylcholine or some kind of agonist of the parasympathetic system. But that's going to come with a lot of side effects, right? So if I give acetylcholine, an agonist, to try and somehow improve the muscles, the neuromuscular junction, I'm going to get acetylcholine side effects throughout the whole parasympathetic system, right? Because it goes into the blood, the medication goes into the bloodstream. So I'm going to get all these parasympathetic side effects. So that's not a great option. What about a drug? So what happens normally to acetylcholine at the neuromuscular junction is that it needs to be broken down. We spoke about how norepinephrine or epinephrine is broken down or taken away from the sympathetic synapse, the synaptic cleft there. So acetylcholine needs to be taken away once it's done its stimulation, and it's taken away with acetylcholinesterase, which is an enzyme that hangs around the neuromuscular junction, and it breaks down acetylcholine once it's done its stimulation. So what if acetylcholinesterase, so it's an enzyme that breaks down acetylcholine. Okay, that makes sense. I have acetylcholine that's secreted by the nerve. It stimulates the muscles, and then acetylcholine has to be cleared by acetylcholinesterase. What if we think of a drug or invent a drug that blocks acetylcholinesterase? That would allow more acetylcholine to stay in at the neuromuscular junction for longer. Okay. So, and there is such a drug. There's a couple of drugs. Pyridostigmine is an acetylcholinesterase inhibitor. So it blocks the breakdown of acetylcholine and allows it to stay longer at the neuromuscular junction because it is inhibiting acetylcholinesterase. Okay, well, that's going to increase strength. That's going to improve your ptosis. That's going to get rid of your diplopia, your double vision. It's going to improve your swallowing. Okay, so let's talk about a medication here. It's not used very commonly because myasthenia gravis isn't very common, and that would be the main reason to use pyridostigmine or mestinon. And remember, I'm just going to remind you here, in myasthenia gravis, there's two parts of the treatment. There's treating the lack of acetylcholine receptors by increasing acetylcholine at the neuromuscular junction, but also the immunosuppressant that we use to treat the overall disease and lower the antibodies in the blood. So what does this medication do to help in myasthenia gravis? Well, it inhibits the enzyme called acetylcholinesterase. And because it blocks that enzyme for a period of time, usually about 6 hours, what it allows to happen is that acetylcholine can build up to higher levels and last a bit longer in the neuromuscular junction, which then can stimulate the acetylcholine receptors that are on the muscles of your body, allowing for more strength of those muscles. So that's the idea behind pyridostigmine. By blocking the enzyme that actually breaks down acetylcholine, you allow acetylcholine to have higher levels in the synapse that then can at least stimulate the remaining receptors more. So what would you expect to happen with this drug? So with taking this medication regularly, you would expect the person to have stronger muscles. So if they had weakness, the weakness should improve. If they had slurred speech, like I just had, that should improve. If they had double vision or ptosis, that should improve by taking this drug through the day. Okay, so the whole idea is to increase acetylcholine at the neuromuscular junction. The adverse effects, well, it's increasing acetylcholine at other junctions in the body, at other nerve junctions. And where do we know acetylcholine exists in the autonomic nervous system? The parasympathetic system at the nerve organ junction, right? So the postsynaptic nerve that is going to an organ such as the heart, the eye, the gut, the bladder, there's acetylcholine there. So this is also going to work at those sites. So you can you can almost predict the side effects of this. So gastrointestinal stimulation, so increased salivation, nausea and vomiting, abdominal cramping, diarrhea. Okay, in the respiratory system, it's going to stimulate the parasympathetic system. So bronchoconstriction, maybe some wheezing, aggravation of asthma, aggravation of COPD, bradycardia and hypotension. So the parasympathetic system, which is being stimulated here, slowing down the heart, lowering the blood pressure. The muscle twitching is because you're not perfect in how you're giving this dosing, so you could get some muscle twitching because you're actually adjusting the acetylcholine dose amount at the neuromuscular junction. And of course, the eye will be much smaller. The pupil, well, you'll have miosis, which is a very small pupil, and that's due to the cholinergic effect. The contraindications. Well, what don't you want to stimulate if you were so what you wouldn't want to stimulate someone who had a urinary obstruction, say from chronic benign prostatic hypertrophy in a male, so a large prostate, and they're just having difficulty urinating, and now you're giving something that's going to stimulate the bladder to contract. Same thing goes with a bowel obstruction. You're going to stimulate the bowel to have increased peristalsis with this drug as a side effect, of course. And if you have a fixed obstruction in the bowel, meaning there's no flow at a certain site, you'll make the discomfort, the vomiting, everything will be worse. Peptic ulcers, shouldn't use this because you're stimulating acid secretion with this drug, since it's stimulating the entire gastrointestinal system. Asthma and COPD is because it'll cause bronchoconstriction from the parasympathetic effects. So what drug can we use if by mistake we give too much pyridostigmine? So if we have too much pyridostigmine on board, we're going to have too much acetylcholine at the neuromuscular junction and in the parasympathetic system, giving you all those side effects. So the prototype medication, or the prototype anticholinergic, is atropine. So atropine is a drug that blocks the acetylcholine receptors from drugs getting to the receptor, or acetylcholine getting to the receptor. So if you have too much acetylcholine because of this drug, we can use an acetylcholine receptor blocker like atropine, and that will stop this drug or it'll stop acetylcholine from stimulating those receptors by giving atropine. Monitoring vital signs is a good idea. Look at the side effects: hypotension, bronchoconstriction, bradycardia. So we'd want to know that someone can tolerate this drug. And lastly, administration. Know a drug administration timeline. So I'm going to give you an example. Say we have someone with myasthenia gravis and they're getting regular dosing of pyridostigmine. And there's two scenarios. The first scenario is they come in and they say, after taking this drug, within an hour or maybe a bit more, I just feel weak, and I have a lot of secretions in my mouth. I get cramping in my abdomen. I don't feel stronger, and my eyes my eyelids don't open as much, and my arms and legs don't feel stronger. Well, that's likely because they're getting too much pyridostigmine. And not only are they getting the side effects in larger quantities or more significant side effects, but they're also getting too much stimulation of their skeletal muscles. And when you have too much acetylcholine at the neuromuscular junction, you would think, well, you should be much stronger if you have lots of acetylcholine. No, if you have too much and it's continually stimulating the muscles get tired quickly. So they actually come in with early onset of weakness. So someone who comes in having taken their drug and they say, every time I take pyridostigmine, it seems like I get weaker. That should be a concern that they have too much acetylcholine at the neuromuscular junction, and that would be called a cholinergic crisis. if they have too much acetylcholine, and we'll come back to that. Okay. And what we want to distinguish from a cholinergic crisis is a myasthenic crisis. So what's a myasthenic crisis? Well, let's use the same person, and they come and say, you know, I take my drug and I feel stronger. My eyelids go up, my speech is better, my arms and legs feel stronger, and then in about 5 or 6 hours, I just gradually get weaker. But it seems to be happening much sooner now. Okay, so you know, so they feel better after taking the drug, and then 4 to 6 hours later, they feel significantly weaker than they used to be. Well, that's an indication that they need more drug. So they're not having enough acetylcholine being maintained at their neuromuscular junction, and after 4 to 6 hours, they're getting weaker. Okay, so that's an indication to increase the dose of pyridostigmine, or to make it more frequent so that they maintain proper levels of acetylcholine in the neuromuscular junction. Whereas the first scenario would be to reduce the dose when they get weak within an hour and they have all these cholinergic side effects. That means they're getting too much pyridostigmine, and you would reduce the dose. Okay, so one's a cholinergic crisis, meaning I have too much acetylcholine, and one's a myasthenic crisis, where I'm running out of acetylcholine, and it's not really a crisis until they're running into trouble with their respiratory system, profound weakness. But let's just say what's happening is that they're running out of acetylcholine sooner than they were, say, a month or two ago. So their disease is progressing, and the dose has to be adjusted upwards, and likely their immunosuppressant has to be adjusted to treat the disease with a higher dose of their immunosuppressant as well. Okay, so we spent some time on the previous slide talking about myasthenia gravis versus a cholinergic crisis. So a myasthenic crisis would be someone who has myasthenia gravis, and they're getting into trouble because they're running out of acetylcholine at the neuromuscular junction. So they're getting profound weakness, maybe difficulty breathing, all the signs of myasthenia gravis, okay? Versus a cholinergic crisis, meaning I have too much acetylcholine at my neuromuscular junction and also in my parasympathetic system. So how can you tell the difference? Well, if you have a myasthenic crisis, it's going to be mainly, I'm profoundly weak, I have double vision, I can't open my eyelids, I have difficulty speaking, and it's all because acetylcholine in the neuromuscular junction is very low. So there's no parasympathetic symptoms at all. It's not affecting that. Okay? So you shouldn't have, you're not going to have drooling and increased secretions and gastrointestinal effects and all the other stuff that comes with parasympathetic stimulation. What about a cholinergic crisis? Well, a cholinergic crisis means I have too much acetylcholine in my system all over. Okay? So if you have a cholinergic crisis, you're going to have tearing, drooling, bradycardia, hypotension, nausea, vomiting, diarrhea, abdominal cramps, all the symptoms of too much acetylcholine in the parasympathetic system. Plus, if you were taking a drug for myasthenia gravis, such as pyridostigmine, and you were taking too much of it, you would have not only all those parasympathetic symptoms from having too much, because it's raising the acetylcholine levels, but you'd also have profound weakness because the acetylcholine is stimulating the muscle so much that you have weakness. That's what happens to a muscle if it gets stimulated too much. It actually stops contracting. So in the first one, myasthenia crisis, weakness all over, all the symptoms of myasthenia gravis. Cholinergic crisis, weakness, because you're stimulating the muscles so much, plus all those parasympathetic symptoms. Okay, so there's a drug called idurfonium, and idurfonium does the same thing. It inhibits acetylcholinesterase. It only does it for a few minutes, very short acting, say 10 or 15 minutes. It's actually not a few minutes, it's about 15 minutes. So it inhibits the action of acetylcholinesterase. And it stops the breakdown of acetylcholine, okay, just like pyridostigmine or neostigmine, but it only lasts for a short period of time. So it's going to give you all the same side effects as any one of those, okay? So it's going to increase the acetylcholine, and we're going to use it as a test called the idurfonium test or the tensilon test. And you wouldn't use it for the same types of indications, right? Because it's or contraindications, GI obstruction, GU obstruction, asthma, peptic ulcer disease, all the same as pyridostigmine. So I'm trying to distinguish between someone who has myasthenia gravis versus a cholinergic crisis, meaning they just have too much acetylcholine in the system. And as we mentioned a minute ago, they're both very similar. Myasthenia gravis, you're very weak. Cholinergic crisis, you're very weak. But the difference is in a cholinergic crisis, you have all those parasympathetic symptoms as well. But say you're not sure, so we give some idurfonium. So if it's myasthenia gravis, you suddenly have some strength. Your droopy eyelids, your ptosis goes away. Your speech improves. Your double vision goes away for a very short period of time with idurfonium. In cholinergic crisis, what does it do? Well, you have too much acetylcholine already. And what's idurfonium going to do? Well, it's going to bind to acetylcholinesterase and allow more acetylcholine to be in the neuromuscular junction and in the parasympathetic system. So it's not going to make it better. It's likely going to make it worse. So it's a test that isn't used as much anymore, but it was a test to distinguish between myasthenia gravis and a cholinergic crisis. Okay. Just an aside here, for myasthenia gravis, we now have antibodies to diagnose this condition. So we don't really use the idurfonium test very much anymore. In fact, if someone came in to the emergency room and we thought they had myasthenia gravis, one of the tests we can do is actually just put ice packs on their eyes. And what the ice does is it allows the neuromuscular junction for a very brief period of time to work much better. So if we put ice packs on droopy eyes and they suddenly say, oh, my eyelids work much better for a very short period of time, we're much more suspicious that it's myasthenia gravis. So idurfonium test, you should know about it, but it's not used as often anymore. We do blood tests looking for the autoantibodies of myasthenia gravis. Okay, so let's just do this one more time so it's it's crystal clear. So myasthenic crisis versus a cholinergic crisis. So a myasthenic crisis just means that someone has either stopped taking their medication and they know they have myasthenia gravis, and they get very weak, and they get all their symptoms of myasthenia gravis back, or someone that presents for the first time with not knowing they have myasthenia gravis, but they're presenting with all the symptoms, the droopy eyes, the weak facial muscles, difficulty swallowing, the weak arms, weak legs. So that's a myasthenic crisis. And the crisis obviously can progress to ventilation problems, breathing problems. You may need to be intubated. So whenever you see myasthenia gravis, what's the worst thing that can happen? Needing ventilation support, potentially having to be intubated. Okay, so let's look at the symptoms of myasthenia gravis. So you do have decreased acetylcholine receptors from this disease. You have normal secretions. There's no parasympathetic involvement here at all. Tachycardia. We'll take. I don't totally agree with that. You can be a bit tachycardia with myasthenia gravis, possibly because you're having some difficulty breathing with myasthenia gravis. Your pupils are usually normal. Remember, this is not a parasympathetic disease at all. It's a neuromuscular disease. The muscles are weak. That should be W-E-A-K, by the way. So that's a myasthenic crisis. Neuromuscular junction, weak skeletal muscles. And when given edrophonium, the symptoms temporarily are relieved. Okay, a cholinergic crisis. Well, this is someone who is either on a drug and they're on some kind of drug that has the potential, if given in overdose quantities, or they're taking too much of it, can cause too much acetylcholine in the parasympathetic system and the neuromuscular junction, such as neostigmine, pyridostigmine, organophosphate poisonings, something that causes excessive amounts of acetylcholine in the parasympathetic system. So what do you have? Increased cholinergic activity. That's the same as saying more acetylcholine in the parasympathetic system. Increased secretions, bradycardia, constricted pupils. That's all parasympathetic excessive stimulation. The muscles are weak and they're fasciculating, meaning they're twitching a bit. Remember, you can get a bit of muscle twitching if you have too much acetylcholine at the neuromuscular junction. And why are you weak? We went over this. You're weak in a cholinergic crisis, just like in a myasthenic crisis, because overstimulation of the muscles of the legs, the arms, the face, the eyes, the eyelids, cause them to stop working because they're overstimulated. And if you were to test this person with a tensilon test, their symptoms would be worse. You're actually making more acetylcholine in the synapse when you give someone edrophonium. Okay, so know the difference. Myasthenia gravis is purely just a neuromuscular problem. Cholinergic crisis is a parasympathetic problem with all of its side effects, plus also the muscle weakness because the acetylcholine has stimulated the muscle so much. So it's not overly difficult to distinguish between the two. All right, so let's look at the signs and symptoms of cholinergic overdose. And we've already spoken about this in different ways. Parasympathetic stimulation or overstimulation. A drug such as pyridostigmine or neostigmine for myasthenia gravis that's given in larger or overdose amounts can cause a cholinergic crisis. There's a group of or a group of drugs or a group of chemicals actually called organophosphates and they're very common in insecticides. It's actually how it kills the insect. And they're on farms. They're pesticides for spraying crops. Very very commonly found in farming communities around the world. And organophosphates bind to acetylcholinesterase, and they bind very strongly to them. And so what happens? Well, you get excessive amounts of acetylcholine in not only in the neuromuscular junction, but in your parasympathetic system, which innervates all the different organs that we've gone over quite a few times. So what happens with an organophosphate poisoning? Or you could see it as a cholinergic crisis, is just think of your parasympathetic system. So if it's overstimulated, there's two mnemonics here if you like mnemonics, but if it's overstimulated, what's going to happen? You're going to get pinpoint pupils. You're going to have a lot of saliva and drooling, tearing from the eyes, urination, maybe even urinary incontinence, diarrhea, defecation, maybe stool incontinence, gastrointestinal cramping, emesis, which is vomiting, and there's the meiosis, which is pinpoint, which is very small pupils. We haven't spoken a lot about acetylcholine in the brain, but excessive acetylcholine in the brain can make you delirious. And that's where the excitation comes in and muddles. It can make you almost, delirious, which is you're confused, you're not aware of your surroundings. So remember that as one of the cholinergic effects as well. Okay, so this slide is totally optional. I put it in here just to give you an idea that there's many anticholinergic drugs. You're going to come across these anyways. You're going to see them on in pharmacology. You may hear about them in pathophysiology. You'll hear about them next semester. So it just helps put it together more. So it's I don't want you to think that we always use a drug for its anticholinergic effects, because sometimes we'll use a drug for another effect, for another action, but it has, unfortunately, anticholinergic properties. So let's look at antihistamines. So diphenhydramine, that's Benadryl. Hydroxyzine is to help with itching. It's called Atarax. These are antihistamines, okay? But they have very strong anticholinergic effects. So if you give an old person a lot of Benadryl or a lot of hydroxyzine, the brand name for that is Atarax, for allergies or for itching, or they're going to get very, very tired and they can get very confused. So we're extremely careful with anticholinergics in old people. Okay, so remember the the acetylcholine system is in the brain, and as your brain ages, those neurons, some of them have been lost. They're not as robust anymore. And when we knock down the acetylcholine system in an older person's brain, they get very confused to the point of delirious, where they have no idea what's going on. So next group, I meant benztropine, very anticholinergic. A lot of muscle relaxants that you can get over the counter. Cyclobenzaprine, methylcarbamol. You've probably seen commercials for for Flexeril, which is cyclobenzaprine, or methocarbamol is Robaxacet. You know how there's commercials of having pins put in your back, and that's the pain, and how these muscle relaxants can help your back pain. Well, they're not overly effective for your back, your muscle spasms, but they're very anticholinergic. So dry mouth, confusion, tachycardia, same thing over and over again. Antidepressants. So in particular, the tricyclic antidepressants, that you can see the first three, you don't need to memorize these. I'm just giving you examples here. These are all very anticholinergic. You can totally expect someone to come back and say, I've got a dry mouth, my vision is blurry, I'm constipated because of the anticholinergic side effects. Antipsychotics, so olanzapine, again, you're using it for psychosis or for schizophrenia, but the downside is its anticholinergic side effects. We'll skip the next one. Antimuscarinics, we're going to talk about, we're going to talk about oxybutynin and tolterodine coming up. They're used for what's called an irritable bladder or urinary incontinence. We'll talk about those. Antiemetics, so medications for vomiting. Some have very strong anticholinergic properties. So prochlorperazine or promethazine. You give an IV dose of one of these to an old person and they're really knocked down. The vomiting may be helped, but now you come back and they're tired and confused, they can't walk, and that's all from the anticholinergic effects. Antispasmodics, that's where we were talking about. Well, you can see there's a couple there. Scopolamine we spoke more about for the patch behind the ear to help with nausea and vomiting and to dry up secretions in a palliative care patient. The first one is for irritable bowel or bowel spasms. We also mentioned one called dicyclamine, which again, anticholinergic to settle down someone with irritable bowel and they're having a lot of symptoms of bowel spasms. Okay, so just examples to maybe just help you understand it a bit more. This slide is not meant to memorize. Okay, so what about medical conditions that older adults may have that can be worsened by anticholinergic? So the first one on this list should be falls. So if you give anticholinergics to old people, and they're often on anticholinergics, their risk of falls goes up significantly. And if you fall as an old person, you're in bed, you've broken your hip, you can get skin breakdown, pressure ulcers. So it's a real problem, anticholinergics in old people. Angina can be worsened. Think of what it's doing. It's increasing the heart rate. So angina, you don't want to increase heart rate. Congestive heart failure, you don't want to increase heart rate. They're constipating drugs because they turn off the gastrointestinal system. They totally aggravate dementia because they block the acetylcholine in the brain. And we're all very dependent on that acetylcholine for our alertness. In diabetes, I think we'll skip that one. That one's not that important. In a heart conduction problem, so if you have issues with conduction of signals in your heart, well, you know that anticholinergics mess with the heart. They block the parasympathetic system, so you could give people a faster heart rate when it was already fast. So careful with people with heart disease. Narrow angle glaucoma, which is that closed angle glaucoma, that's one that seems to come up a lot. And anticholinergics definitely make your eyes dilate and can put you at risk for an acute episode of narrow angle glaucoma. okay, where the iris has been bunched up and the eye is super dilated, and now the fluid from inside the eye can't drain out because the iris, which is bunched up, is blocking the flow. Prostatic hypertrophy. So an anticholinergic is basically going to turn off your bladder muscle, the detrusor muscle, to contract. It's going to weaken it. So if you were already relying on your bladder muscle to force that urine out through the narrowing in your prostate gland, well, now you're going to put someone into urinary retention. They just can't get the urine out anymore because you've weakened the contractions to the detrusor muscles. Ulcerative colitis or any gastrointestinal disease, you're turning off the gastrointestinal system with anticholinergics, so a lot of them get flare-ups of their illnesses like ulcerative colitis, Crohn's disease. So very careful with people with gastrointestinal diseases. Urinary dysfunction. Well, we just mentioned that it actually weakens the bladder contractions because the bladder is very dependent on parasympathetic stimulation. So anyone who has a lazy bladder, an atonic bladder, if you give them an anticholinergic drug for something else like depression, and they come back and say, you know what, I can't urinate anymore. Well, that's the anticholinergic side effect. Okay, so let's go on to cholinergic antagonists. So a cholinergic antagonist is just the opposite of a cholinergic agonist. You're going to block the parasympathetic system. And if you block the parasympathetic system, you will get very typical effects and very predictable side effects. And we'll go over them. And there are drugs in this group that are used very commonly. And also, there's many drugs and drug groups that are used for depression, for allergies, for all kinds of things that have anticholinergic side effects. So remember that term, anticholinergic side effects. Because say you're using Benadryl, diphenhydramine for allergies in the springtime. Well, that has a lot of anticholinergic side effects. And it's important to know that so that certain people don't take these medications. Okay, so we'll go over that a bit more. So atropine and other similar drugs, there's one called scopolamine, there's another one called glycopyrrolate. They're worth knowing. They're all in the anticholinergic group. You could also say parasympatholytic group. So there's just different ways to name the same group. So atropine is definitely the prototype of an anticholinergic. It blocks acetylcholine from getting to the receptor at the target organ, whether it's the heart or the gut, gastrointestinal tract, or the bladder, and it will have very specific effects at all these organs that have receptors for the parasympathetic system. So let's look at the indications for atropine. So antidote for muscarinic agonist. Okay, so say you're giving pyridostigmine to someone who's taken too much of it. And they were taking it, by the way, for myasthenia gravis. And now they have too much acetylcholine at the neuromuscular junction, plus too much acetylcholine in the parasympathetic synapse. Well, you can use atropine to block the effects of the excessive acetylcholine. Organophosphate insecticides. Well, if someone came in heavily poisoned with organophosphate insecticides, we would definitely use atropine to block its effects. Muscarinic mushrooms are mushrooms that if someone inadvertently picks mushrooms while they're hiking on a trail and eats them, some of them can be very cholinergic, and they can produce large amounts of acetylcholine, and they can come in with a cholinergic crisis. And atropine would be used to treat them. Nerve gas agents. So nerve gas agents work the same as organophosphates. They block acetylcholinesterase, which produces large amounts of acetylcholine, and they get all those parasympathetic effects. So if you were to look online at sarin gas poisoning, you would see cholinergic effects of people that are tearing, drooling at the mouth, diarrhea, vomiting. It's actually quite awful to see. And the treatment for that would be atropine. Symptomatic bradycardia. So someone comes in with a heart rate of 30. Well, we could use atropine, depending on what the rhythm is, but just say that it's a rhythm that's very, very slow, and it's a rhythm that we're happy to use atropine in. We could give atropine to block the parasympathetic so that the sympathetic system accelerates the heart rate. Okay. Drying up secretions for pre-op patients. So we do this all the time. They may have an injection of atropine or glycopyrrolate because they're having oral surgery where there's a lot of secretions in the mouth, and the surgeon may need to have a very dry field for surgery. So they'd get a dose of atropine or glycopyrrolate, and that would dry up the secretions because the salivary glands are very dependent on the parasympathetic to continually make saliva. So an anticholinergic would dry up the secretions by blocking the acetylcholine and thereby reducing oral secretions. Or even in a palliative patient, we use scopolamine patches. So scopolamine is an atropine-like compound, and we can use scopolamine patches behind the ear, and that really dries up oral secretions, respiratory secretions, and nasal secretions in someone who is palliative and in the process of dying, and they have a lot of wheezing and rattling in their chest. So anticholinergic really dries up secretions. And if you think about how, what produces a lot of secretions, the parasympathetic system. So if you block the parasympathetic, you'll dry up the secretions. What else do we use scopolamine for? So what about if you're going on a boat and you get terribly seasick and you've experienced the feeling of seasickness before? Well, you can put on a scopolamine patch behind your ear. That has a lot of anticholinergic effects, and because seasickness is a type of dizziness, and the cholinergic system is involved in that, by using an anticholinergic like scopolamine, you can prevent seasickness from happening. Okay, so let's look at the actions as it blocks muscarinic receptors. So it blocks acetylcholine receptors at the target organs, so that the acetylcholine can't act on those receptors. It doesn't really stimulate the sympathetic response, but it allows the sympathetic response to have more power because you've turned down the parasympathetic response. Okay. What about adverse effects? Well, uh, some of the adverse effects are some of the indications. They're actually mixed together, right? So drying oral and nasal mucosa, oh yeah. So if you take atropine, you're going to have a very dry mouth. If you take atropine or scopolamine or glycopyrrolate, you're going to have constipation. It's turned off the GI system. Urinary retention in old people, so anticholinergic drugs stop old people from urinating. Tachycardia, right? You've allowed the sympathetic system to have more influence. Ventricular fibrillation, I think we'll leave that one. That would be a bit of an unusual adverse effect to atropine. I mean, I guess if you gave such an overdose of atropine and you made the person so tachycardic that they finally went into this, pre-death rhythm of ventricular fibrillation, it's possible, but we're not going to focus on that one. Blurry vision. Well, what does it do to the eyes? It's an anticholinergic, so the eyes are going to dilate, right? Photophobia, so painful eyes when looking at light or sunlight. Well, the eyes are so dilated that you're allowing a lot of light in, and the pupil can't constrict because of the atropine-like compound. Delirium, so old people. Because acetylcholine, I mentioned in a previous slide, uh, is a neurotransmitter in the brain, and it's a neurotransmitter that's used for the awake state, meaning acetylcholine is responsible for alertness. So it's involved in a lot of nerves in your brain that manage your level of consciousness, your alertness. If you block that system with an anticholinergic, especially in old people, you can have fatigue first, confusion, increased risk of falls because they're not walking well anymore, and then finally delirium, where the system's been shut off so much, the acetylcholine system in the brain has been shut off so much that they're delirious, and then finally they can go into a coma if it's completely turned off, which would be a bit unusual. It would have to be a huge overdose. Contraindications. Well, because it dilates the eye and it squishes the iris so the iris dilates, right? And you have a huge pupil. Well, all that iris tissue is squashed up against the side of the eyeball. You can run into problems with acute angle closure glaucoma. So if you have a history of angle closure glaucoma, then you wouldn't use an atropine type compound because it'll dilate the pupil, the iris will bunch up against the corners of the eye and it'll stop. It'll obstruct the outflow of fluid within the eye and lead to very high pressures. Cardiac conditions, you have to be careful with atropine because it speeds up the heart. Okay. COPD. It's not really a huge contraindication in COPD. I'll have to check on that one because we use anticholinergic drugs for COPD. So might want to just cross that one off or highlight it. I don't think that's a big issue. Myocardial infarction, well, you get tachycardia from atropine, so you wouldn't want to use it in heart conditions such as an MI or heart failure, or at least we'd be careful with it. Ulcerative colitis is a gastrointestinal disease, and remember, what's this drug doing? It's turning off the gastrointestinal system by blocking the parasympathetic. So you're going to get constipated. You're going to get less less peristalsis, less secretion. So it can really aggravate gastrointestinal diseases. And Down syndrome is there only because people with Down syndrome have heart conditions. They can have holes in their heart. They can go into heart failure. So that's why Down syndrome is there. So what about nursing responsibilities? So definitely vital signs. This can definitely make you tachycardic. Input and output. Well, we mentioned how it really dries up secretions. CNS status. This can cause major confusion in old people. We're very careful with anticholinergics in old people. Atropine fever. You can get a fever with atropine because of what it's doing in terms of blocking the acetylcholine at the sweat glands. Remember, the sweat glands use acetylcholine in the sympathetic system. So if you really shut down the sweat glands with atropine, you can get a fever with it because they can't release as much, the patient can't release as much heat from themselves. Intraocular pressure during procedures related to cycloplegia. So this one, we use atropine type compounds as drops for eye procedures because it dilates the pupil, right? And when you dilate the pupil, you get a very good view within the eye. But the intraocular pressure needs to be checked because remember, when we dilate the eye, there is a small risk of increasing the pressures in the eye because we've potentially blocked the outflow of the intraocular fluid because the outflow is exactly where the iris has to dilate and bunch up against the inner eye. Okay. Okay, so cholinergic blocking agents is the next slide, or anticholinergics, right? So if you go to the store right now and you look at over-the-counter drugs, many of them will have anticholinergic side effects. And on the box it'll say, don't take with cardiac conditions, don't take with a history of glaucoma. And if you see that, it's likely because it has anticholinergic side effects. So let's just look at, I'm just gonna look at a couple of these. I don't think it's necessary to know every one of these, but let's just look. So atropine we spoke about. Probably the most common reason we use atropine is to dry up secretions, and we use it in symptomatic bradycardia to speed up the heart rate. Scopolamine, it's an atropine type compound. It's usually turned into a small patch and put behind the ear for nausea, seasickness, and to dry up secretions in palliative care patients. We once had a nurse that put a scopolamine patch on and then touched her eye and came over to ask me what's happening with my eye. Her eye was completely dilated. I couldn't even see the iris anymore. And it's because she had touched her eye with her hand that still had some scopolamine drug on her hand. So that lasted the whole day. Synthetic ones, I don't think so. Ipratropium is an anticholinergic, and it comes in an inhaler for COPD. So if it's anticholinergic, it's going to help bronchodilate. Okay. Oxybutynin we're going to talk about in a minute. Tolterodine we're going to talk about. Benztropine is a medication that you may remember. It's used in Parkinson's disease, and it's also used to treat extrapyramidal side effects. So if someone's taking a drug like Haldol, haloperidol, and they get extrapyramidal side effects, the treatment for that is an anticholinergic, such as benztropine. Okay, and as I mentioned, benztropin's also used in Parkinson's disease. And the last ones, so you notice I skipped the first one, dicyclomine. That one's used in irritable bowel syndrome, which is kind of a crampy, irritable spasms of your small intestines, and very, very common condition. And what happens is they have so many cramps, discomfort, sometimes diarrhea, that sometimes we'll use an anticholinergic drug just to settle down the gastrointestinal system and stop it from contracting as much. So, so just remember, like, don't try not to get overwhelmed by these. That they're all in the same group, right? So when I look at this page, I just say these are all anticholinergic drugs. They've just been chosen for different um, conditions, but they're all anticholinergic. So if I could turn atropine into a spray bottle or an inhaler, well, I'm going to call it ipratropium now because that's the chemical that's the anticholinergic we use as an inhaler. If I want to relax the bladder as an anticholinergic or an antiparasimpatholytic, well, I'm going to make something called oxybutynine because that's the one we use to relax the bladder, and we're going to talk about that one. Glycopyrrolate we can use as an injection for palliative patients. It really dries up secretions, and preoperative patients, especially for oral or gastrointestinal surgery to really dry up secretions. Homatropine, it's a short-acting atropine, and we use it in the eye. So why would we use it in the eye? So we really want to get a good look at someone's retina, but it's very hard to see the retina when your pupil is so small. So we put some homatropine drops in, and it usually lasts couple of hours. It can last the whole day, actually. And then if we come back in 20 or 30 minutes after having put homatropine drops in, the pupil is nice and dilated. Okay. Remember, scopolamine, when the nurse put that patch on, that would do the same thing to the eye, but that doesn't come in a drop form. We use homatropine. If we wanted someone's eye to stay dilated for a week, we could put atropine drops in because atropine lasts much longer in a drop form than homatropine. Most of the time we wouldn't want to do that, to have an eye dilated for a long time, because now they're going to leave the clinic or the hospital and their eyes dilated, and they're going to complain about sunlight. They're going to have to wear sunglasses to protect their eye from the light. So these are all just different compounds in the anticholinergic group. Okay, so we're going to spend a bit of time talking about the bladder. So the bladder is basically a holding container for urine, so that without the bladder, if we didn't have a bladder, we'd just continually leak urine down our legs. So we need that holding container, just like we need the rectum for stool, so that we can have a bowel movement at an appropriate time. Well, we can urinate at an appropriate time by storing urine. And the bladder is a muscle, and it's able to forcefully contract and expel the urine through the urethra. So let's look at the slide on the left. What happens normally? So the urine will gradually expand the bladder. It'll send a signal to your brain, and then you'll get stimulation returning when the bladder is full to contract through the parasympathetic system. Okay, and it'll contract the bladder, and also the parasympathetic system will relax the bladder sphincter. Okay, what about an overactive bladder, or what we call an irritable bladder? Well, the bladder starts to fill, but it becomes a bit unpredictable when the bladder's going to contract. So it might fill a bit, and then it wants to contract and release the urine immediately. And this is a much bigger problem in women than men, and they can become incontinent, urinary incontinent. So, you're sitting in class, and if you have an overactive bladder or an irritable bladder, you have sometimes very little warning from when you get the signal to your brain that you need to urinate to then make it to the washroom. And often, for some women, they don't make it to the washroom. They're incontinent of urine because the bladder is already contracting and it's already relaxing its sphincter, and they're not able to hold their urine appropriately. So it's hard to get through a day if you have a very overactive, irritable bladder. So there's a number of so you could ask, well, why does this happen? Well, it's often the bladder muscle itself that's irritable, and as it expands with the urine in it, sometimes the irritable bladder muscle just contracts forcefully, and you're incontinent of urine. So let's talk about this on the next slides, and we'll talk about some drugs about an overactive irritable bladder. Okay, so let's talk about a drug called oxybutynin. Again, we're in the anticholinergic group. So, and there's one that's similar to it. It's a newer one. So oxybutynin's been around for a long time. There's another one called tolterodine, and I think the brand name for that is Detrol. They basically do the same thing. The bladder is highly dependent on parasympathetic nerves for muscle contraction, detrusor muscle contraction, to force the urine out through the urethra. So if we have a very twitchy and very irritable bladder, we never know when it's going to contract. We never know when it's going to empty itself. That's not great for daily living because you're going to be incontinent and you're going to have urges all the time. So we want to settle down the detrusor muscle of the bladder with a medication, with an anticholinergic drug. And oxybutynin is the prototype for this one, right? So it prevents contractions of the bladder and it allows it to fill more before you have this strong urge to urinate. The adverse effects, I almost don't feel like going over anymore because I think by now it's an anticholinergic. Just think of every anticholinergic side effect. You could get any of them with oxybutynin or with tolterodine, okay? Just because they make a drug for the bladder doesn't mean it's going to give, it's not going to give anticholinergic side effects elsewhere. Okay, because you're taking advantage of the anticholinergic side or effect on the bladder, and that's how you want it to work. But it's not like it's just going to choose the bladder; it's going to go all over. Okay, contraindications, same thing. Who would you avoid this in? Acute angle closure glaucoma. Definitely, if someone had myasthenia gravis, you wouldn't want to block the acetylcholine. Certainly, if someone had an ileus is where your bowel isn't moving food or fluid through it, and paralytic ileus is usually in the setting after bowel surgery. So you've had your bowel operated on, and the whole system has turned off. The bowel says, "Whoa, I just had surgery. I'm turning off," and it could be for a day or 2 or 3 days, and that's called paralytic ileus. And you can't drink, you can't eat because nothing's moving through the system. There's no blockage, it's just that the system's not contracting at all. So that's why prior to discharge from a hospital, we like to see that people are at least drinking fluids and tolerating oral fluids, and sometimes even foods, right? Because that means they don't have paralytic ileus. GI or GU obstruction, okay? Well, if you have a lazy bladder or a lazy gastrointestinal system, lazy small intestine, what's oxybutyn going to do? It's going to slow it down even more, right? So if you have a history of urinary retention, meaning you don't really empty your bladder that well anyways, typically an older man with a prostate issue, he's forcing his urine out, and then you give him oxybutyn, and then he can't even contract his bladder muscles anymore. Okay, so avoid in older patients. Well, anticholinergic turns off the brain activation, reduces alertness, and down they go. Clients with GERD. I wouldn't spend too much with this one. It can relax the lower esophageal sphincter and aggravate gastroesophageal reflux disease. We'll get to this. I think you'll do this more in pathophysiology as well, gastroesophageal reflux disease. Heart failure, purely because this is an anticholinergic and it's going to speed up your heart. Kidney or liver impairment. So if you have severe kidney or liver impairment, it's almost most drugs aren't indicated because that's how they're processed and secreted, right? Or excreted. So I would just remember the anticholinergic side effects. So nursing responsibilities, increasing clients or instructing clients to increase dietary fiber. Yep, they're going to get constipated on this drug from anticholinergic side effects. Consume proper amounts of fluid in a day, otherwise they're really going to get not only dehydrated, but they're constipated, but they're going to have a dry mouth all the time, right? All the secretions have been turned off, so they need to make sure that they're drinking properly. Sipping fluids to avoid having that dry mouth. Having a little glass of water at the bedside, because the medications that you're using give you a very dry mouth. Avoiding driving and other hazardous activities, for sure. Whenever we prescribe medications that have anticholinergic side effects, we always warn people, this could make you tired, this could make you confused. In older people, we warn them about driving or potentially doing anything that's hazardous, like deciding to go on a ladder and clean the roof off, or anything that could put them in harm's way, and then the drug makes them either tired, confused, or potentially increased risk of having a fall. Okay, so we're off of the autonomic nervous system for now. We're going to go back to the neuromuscular junction. And we were there with myasthenia gravis, talking about the receptors that were destroyed by this autoimmune disease. But now we're going to talk about the neuromuscular junction in terms of paralyzing someone, which sounds a bit strange. Like, why would we want to paralyze someone? But we do, and it's happening in hospitals all the time, every day, that we want to paralyze them. So we have very effective drugs that block the neuromuscular junction and paralyze all of someone's skeletal muscles. Okay? Now, does it turn off your brain? Nope. You're fully awake inside. So this almost sounds like a torture. You're fully awake and aware inside, but you can't move anything if you were just given this drug. You can't move your eyes, you can't talk, you can't move, you're completely paralyzed, So it's almost like a locked-in syndrome where you know what's going on the inside. Oh, and by the way, you can't breathe either. Okay, so total neuromuscular blockade. And these drugs were discovered by an old drug from years ago from in South America, where natives used to put this drug called curare on their arrow tips, and when it punctured the animal, the arrow may not kill the animal, but the curare, which is a neuromuscular blocker, would completely paralyze the animal, and they'd obviously go down and die. Okay, all skeletal muscles stopped working. So um, so curare isn't isn't an active. We don't use curare in hospitals now. We use other drugs that we're going to come to. But curare is the origin of these drugs, because it is. This is how we discovered that we can completely block the neuromuscular junction, which will lead to complete paralysis. And it was used many years ago by South American Indians. So interesting. So let's talk about some neuromuscular blockers, paralyzing agents. Okay. So there's two groups of them. The first group, and this will make more sense in a minute. The first group are, and there's only one in this group, is a depolarizing neuromuscular blocker. And then we're going to talk about non-depolarizing neuromuscular blockers. And it makes a difference, and it'll make sense later. Okay, so just ignore that sentence about depolarizing and non-depolarizing. But there's two groups. So why do we want to paralyze someone? So you come to a hospital to be paralyzed. Why are you going to be paralyzed? Well, for surgery, there's many surgeries that we don't want anyone moving at all, right? Say you're having gastrointestinal surgery. Well, the surgeon wants to make sure that he or she is cutting in the right area and accurately. So all kinds of surgery, brain surgery, heart surgery, don't want the person moving at all. So these are very commonly used drugs. If we do procedures in the emergency room, like intubation, they need to be paralyzed, because if they're not paralyzed, the muscles, when we go to try and get a tube down someone's throat, are still can contract in the neck and make it much more difficult to intubate, to get an endotracheal tube into their trachea during intubation. If you paralyze someone, all those muscles are completely flaccid now. You can lift up, you can look into the airway with your laryngoscope, and it's a much better view. Now, when we paralyze someone, they definitely can't be awake. They have to be unconscious. So we use powerful sedatives to make someone unconscious and unaware of the fact that they're completely paralyzed and not breathing. Otherwise, if you just gave one of these agents without a complete, like a very powerful, deeply sedating medication, that would be torture, right? And they become totally dependent on an airway. Someone needs to breathe for them, right? So intubation is a very common reason. So short procedures, the main one that would fall into that group is intubation. Okay. Let's go to actions. So this drug, so look at the name of it, succinylcholine. Kind of sounds similar to acetylcholine, Well, the last part does anyways. And it causes profound muscle paralysis. And how does it do that? Well, it goes to the neuromuscular junction after you've given it intravenously. And within about 60 seconds, it has stuck itself to all the acetylcholine receptors at the neuromuscular junction and depolarized the muscle over and over again until, remember, if you depolarize a muscle and you stimulate a muscle, it goes to complete paralysis, right? The muscle no longer contracts. That's exactly what this does. So it sticks to the acetylcholine receptor and depolarizes the muscle, and then you have complete paralysis, usually in about 60 seconds. So the adverse effects, although these aren't really adverse effects because the first two you want, this is an expected effect. Paralysis of the diaphragm and the intercostal muscles, that's totally expected, okay? And remember, one of the main reasons for using succinylcholine is to intubate someone. You know you're going to completely make them apneic. They won't be breathing anymore. And that's going to make, and not only that, but all their muscles are going to be completely flaccid. So it'll be very easy to open up their mouth and get a very good view of the airway to put your endotracheal tube in. Now, because it mainly works at the neuromuscular junction, but if you think about it, it is kind of working as a parasympatholytic a bit too, right? So it's sticking to the acetylcholine receptors and not allowing them to accept acetylcholine for about 6 to 8 minutes, by the way. So if you get an injection of this, you're paralyzed for 6 to 8 minutes on average. So it wouldn't be unusual maybe to expect a bit of tachycardia, maybe a bit of hypotension, possibly a bit of urinary retention. Respiratory depression, well, it's respiratory apnea, no breathing for 6 to 8 minutes, right? So when we give it in a hospital, we're very aware of the fact that we're paralyzing their respiratory system. We're turning it off, and we're going to be breathing for them. Malignant hyperthermia. So really, there's succinylcholine that can cause malignant hyperthermia, and it's a severe reaction to the medication. It's actually a genetic disease, so it runs through families. Luckily, people often have bracelets warning us that they have malignant hyperthermia, MH. And what happens is when you give succinylcholine, and the other group that can cause it is some general anesthetics can also lead to these. Some of the gas anesthetics. So this doesn't happen with the other group that we're going to talk about in a minute. This just happens with succinylcholine. Okay. And what is malignant hyperthermia? So this severe reaction you get when someone is administered succinylcholine, they suddenly get muscle rigidity, okay, high fevers, extremely fast heart rate, and the muscles are so rigid that the muscles start to break down. And when the muscles break down, potassium and all the enzymes within the muscle, CK, breaks down, and it can lead to high potassium in the blood, and it can lead to rhabdomyolysis, which is a severe muscle breakdown leading to kidney injury or renal failure because you've clogged up the kidney with all these toxins and muscle cell breakdown products. So if someone in your family, or there's a family history of malignant hyperthermia, Everybody in the family gets tested because we would want to know before they have any surgery and before they receive either succinylcholine or one of the gas anesthetics. Um, we would want to know this because we would avoid giving those drugs. So malignant hypothermia. Remember the symptoms of malignant hypothermia. Someone who develops a very high fever, muscle rigidity, hyperkalemia, tachycardia. Something very wrong has happened after administration of this drug. And just as an aside, malignant hypothermia, you'll need to know a bit about it, and I'm just gonna just put this out there. The treatment for it is a drug called dantrolene. Okay, so we reverse this with a drug called dantrolene, and I think we talk about that at some point. And we also provide rapid cooling measures to get their temperature down quickly because they can have incredibly high temperatures, fevers. Okay, so let's go on to contraindications of succinylcholine. So the way succinylcholine works is it goes to the acetylcholine receptor at the neuromuscular junction and just stimulates it over and over and over again until the muscle just says, okay, I'm not contracting anymore. So when we give succinylcholine, in the first 60 seconds, what we're actually seeing when we look at someone's body, waiting to intubate them, is that the muscles are twitching everywhere. They have what's called fasciculations, because that is the acetylcholine, or sorry, that's the succinylcholine stimulating all these muscles everywhere, and all their skin is kind of fasciculating and contracting the muscles. And then at 60 seconds, boom, everything's paralyzed, usually around 60 seconds. So that stimulation of the muscle for the first 60 seconds typically increases your potassium level by about 1. So if you have a history of hyperkalemia, do we really want to put your potassium higher? So who potentially has a high potassium to begin with? Well, someone with renal failure, someone with who's receiving dialysis. So if we see a dialysis fistula, we won't use succinylcholine. Who else could have hyperkalemia? What about a massive crush injury? So someone's been run over by a car and their muscles of their legs are all crushed. Well, they've released a lot of potassium into their bloodstream from all these crushed cells. So we may avoid succinylcholine in a massive crush injury. What about someone who's severely burned? Well, if they're severely burned, they've released incredible amounts of potassium from all these burned cells, and succinylcholine is going to raise the potassium. So we wouldn't use it in a burn patient. And the last one is someone who's had some kind of musculoskeletal disease. So they have a childhood congenital muscular disease, cerebral palsy, something where the nerve to the muscle hasn't been functioning for a long time. And then if we give succinylcholine, it's suddenly going to stimulate these muscles that haven't been stimulated for a long time because the nerve wasn't doing it. They had some kind of neuromuscular disease to begin with, like a childhood neuromuscular disease. So suddenly we stimulate with succinylcholine and they release tremendous amounts of potassium because the muscle hasn't been stimulated in so long that it's not used to being stimulated, and it just releases large amounts of potassium. Another example is someone who's had a stroke. Okay, so if they've had a large stroke, those muscles haven't been stimulated. The nerve from the brain to the muscle has been permanently damaged and they've been paralyzed, say on one side, for example. Those muscles haven't been used, and now you're giving succinylcholine. So these muscles haven't been stimulated in months to years, and now you're injecting them with succinylcholine. And remember what succinylcholine does, it stimulates the muscle first for the first 60 seconds. And that, because these muscles haven't been stimulated in so long, they're going to release large amounts of potassium. Okay, so who do you avoid succinylcholine in? Someone with a history of high potassium, someone with renal failure, a child with some kind of neuromuscular or muscular disease like Duchenne's muscular dystrophy or cerebral palsy, a massive crush injury, someone who's had a stroke in the past. So most of it is about causing high potassium. So any disease that you have the potential to elevate their potassium, and they already are at risk for having high potassium, we would avoid succinylcholine. Okay, so kidney dysfunction or kidney failure. All right. So the nursing responsibilities. So because we use this frequently in intubation of patients, ensuring intubation. How do we ensure intubation? Well, we listen to the lungs on each side to make sure they have proper air entry. We often do a chest x-ray to see the tube is in the trachea. We'll attach them to an O2 sat monitor and actually a CO2, an end-tidal CO2 monitor to see that the air that's coming out of the lungs actually has CO2 in it, and that tells us it's in the trachea. We always have to monitor the airway to make sure that tube doesn't come out. And of course, when they're on succinylcholine, they need pain control because they have a tube in their throat and that's uncomfortable. And by the way, they're totally paralyzed. They can't tell you that it's uncomfortable. And they have to be fully sedated in order to tolerate and not only the tube, but to be unaware of the fact that they're completely paralyzed for 6 to 8 minutes. Okay, we do check electrolytes, in particular potassium, right? So think about all those people. There's not that many that can't have succinylcholine, but it's the ones where you can, because we know we're going to make the potassium go up a bit with succinylcholine. So it's the patients that already have the potential to have high potassium. And we usually tell people after receiving succinylcholine, you may have some achy muscles. And that was because for the first 60 seconds, they fasciculated and contracted. So they might say, you know what, all my muscles are achy after having had succinylcholine. Okay, so we're still talking about the only depolarizing neuromuscular blocker, succinylcholine. Okay, and it's used as part of anesthesia, as the paralytic part, to keep a patient completely still, paralyzed during a procedure. It's used for intubation, so we would use a powerful sedative plus, for example, succinylcholine if we chose this one. And the succinylcholine gives the muscle paralysis so that it makes it very easy when we look into the throat with a laryngoscope. The muscles are completely paralyzed. They're very easy to lift up and move out of the way so we can get the tube in. Okay. It's very fast acting. It lasts, it activates in about a minute. And as I said, before that minute, you could look at the skin and you can see all the little muscles fibrillating, twitching a bit. And that only happens with succinylcholine, by the way. The other ones we're going to talk about won't do it, and they'll make sense later. And in general, it lasts in the 4 to 6, maybe 8-minute range, short acting. So it's kind of nice that way. If we can't, for example, if we go to intubate someone and we've completely sedated them and given them succinylcholine, if we have a lot of difficulty intubating them and we just can't get the airway in, we can we can just bag them. We can just put a bag valve mask on and bag them, ventilate them until the succinylcholine wears off, which is anywhere from around 4 to 8 minutes. So that's a nice thing too about succinylcholine, that it wears off relatively fast. Succinylcholine, what is malignant hypothermia? So that's that genetic disorder. So hopefully it's diagnosed in the patient prior to them receiving succinylcholine, because a family member has it and then they were checked. If we didn't know, then they get all those symptoms of malignant hyperthermia, the fevers, the rigidity, the hyperkalemia, the muscle breakdown, the tachycardia, hypotension. And what's the reversal agent? A drug called dantrolene. What's the black box warning for this drug? For use in, there's a black box warning for use in children. So why is that black box there for children? That seems kind of strange. Well, the black box exists there because children can have undiagnosed congenital muscular disorders. And remember, if they have some kind of congenital muscular diagnosis or muscular dystrophy or something that we just don't know about yet, and they're given succinylcholine, well, succinylcholine stimulates, it depolarizes the muscles that leads to paralysis. And if you depolarize muscles that haven't been used in years, such as in children with an undiagnosed muscular dystrophy, you can cause profound hyperkalemia, high potassium. And what are we afraid of when the potassium is high? Cardiac arrhythmias and cardiac arrest. Okay. Okay, so what drug order would you expect to reverse this medication? Well, there's a problem there. There is no reversal agent for succinylcholine. So if you understood how it works, then it binds to the acetylcholine receptor and depolarizes the muscle. So we actually have to wait for the drug to wear off, and that's what we typically do. We wait for it to wear off, and it wears off usually in 4 to 8 minutes. So, you know, as I said, if we're doing an intubation and it's a failed intubation, we couldn't get it in on the first attempt, then we'll ventilate and bag the patient until the drug wears off. So there was really no reversal agent for this. We just allowed time to allow succinylcholine to separate from the receptors, and then the person starts to spontaneously breathe again. They get their muscle, the paralysis resolves. And don't forget, we're doing this while they're completely asleep, right? We're giving them drugs to keep them completely asleep so that they're not aware of any paralysis. Okay, so let's talk about the second group of neuromuscular blockers. And these are indicated for very similar reasons, to paralyze a patient for a surgical procedure, or paralysis for endotracheal intubation. They typically last longer than succinylcholine, and we'll get into that in a bit. And so how do these work, and why are their side effects different? Actually, why are there almost no side effects? The action of this is this competes for the acetylcholine receptor at the neuromuscular junction. So you have acetylcholine there, and you have one of these agents, pancuronium, rocuronium, or vecuronium, and we give them intravenous for paralysis, and they compete for the neuromuscular junction. So they still cause complete paralysis, but they're not binding to the receptor and sticking there. So they don't cause those fasciculations the twitching, because they're not binding and repetitively making the muscle contract. They're not causing hyperkalemia because they're not making the muscle repetitively contract. So they're just competing for the receptor that acetylcholine was binding to. So they make the acetylcholine and the receptor just not get together for a while. So they're called competitive neuromuscular blockers. So they're competing with acetylcholine. Okay. So because they don't bind to the receptor and depolarize the muscle, you don't see all of those hyperkalemia side effects, and you don't see all the contraindications like you would for succinylcholine. So let's look at the adverse effects, and I think you know what I'm going to say already. These adverse effects are actually the effects of this drug, right? So we wanted paralysis of the skeletal muscles. Oh, by the way, intercostal muscles and paralysis of the diaphragm go with it, right? So we completely make the person stop breathing with these drugs. But really, it's expected. It's kind of hard to call it an adverse effect when it's expected, right? It's an expected action of the drug. Contraindications, there's next to none, right? Hypersensitivity to bromide, but that's a minuscule contraindication. Almost no one's sensitive to bromide. Experienced provider, that goes for succinylcholine or any of these non-depolarizing neuromuscular blockers, because you're actually paralyzing someone and you're stopping them from breathing. You're making them apneic for a period of time. So you have to have an experienced provider that can intubate the patient, okay, that can provide airway and breathing support. So let's look at the drugs at the top. I would say of all those three, rocuronium is the most common, especially in the emergency room and the ICU. So why is it the most common? Look at the length of time. So 20 to 30 minutes. That's a good amount of time to do most things that you want to do, such as intubation. So when we're talking about intubation, getting an endotracheal tube into someone's trachea so we can ventilate them, it typically doesn't take more than a couple of minutes once you've paralyzed them. So succinylcholine or rocuronium are by far the most popular agents in North America. There's other ones in this group, but look at the length of time. They'd be more for surgical procedures in hospitals. Vecuronium, 30 to 45 minutes. Pancuronium, 90 minutes. So those would be more for surgical procedures as opposed to endotracheal intubation. They work exactly the same. It's just the length of time. Okay. So these are significantly easier to use. The problem is they last longer, but you don't have to think about as much the contraindications and the adverse effects of the hyperkalemia. So rocuronium is quite popular for that reason, although succinylcholine is still used commonly. Nursing responsibilities, ensuring intubation, and ensuring that the tube doesn't get dislodged during transfer to another bed. That tube can become dislodged out of the trachea, and then of course not being ventilated anymore, but still paralyzed. So we monitor the airway very closely. These patients need ongoing pain control intravenous with opioids, with narcotics, and sedatives to keep them unconscious while being paralyzed. Okay, so we use powerful benzodiazepines. We can use a drug called propofol, which you may have heard of. We do monitor electrolytes, but we don't have the fear of hyperkalemia with these drugs. Teaching the patient that they may have post-op muscle pain is a much smaller issue with these drugs Because remember, they don't get the twitching like in succinylcholine, because succinylcholine depolarizes the muscle and makes the muscles twitch for the first 60 seconds. These don't do that. So this next slide, I'm not going to spend too much time on. So non-depolarizing. So if you see non-depolarizing, or if you see rocuronium or pancuronium, you know that it's the total opposite of succinylcholine. It does not stick to the receptor and bind to it and depolarize the muscle and cause all those issues. These just compete for the receptor with acetylcholine that's in the neuromuscular junction. Okay, so definitely a skeletal muscle paralytic, used for intubation. They definitely need to be ventilated if they're receiving this drug because they're paralyzed. Sometimes we do use it when someone's having a seizure that we just can't stop. We'll use powerful sedatives and anti-seizure medications to stop the seizure, and we'll use a paralytic agent to stop the muscle activity of the seizure, all the flopping around of their arms and legs, okay? And they're typically used for lengthier procedures compared to succinylcholine. And there's the time frame for pancuronium. Look how long it is. So in hospital, prolonged procedure, surgical unit, rocuronium, emergency room, ICU. We use it for intubation very frequently. So just know a bit about the different time frames and know the difference between a non-depolarizing agent, such as these, versus a depolarizing agent, such as succinylcholine. Okay, and here's the list again. So on the one side, all by itself, is succinylcholine in the depolarizing group. It's given IV. It's usually given at exactly the same time or just after the sedative agents and the analgesic agents. So something like propofol as a strong sedative, and a short-acting narcotic such as fentanyl. Not that you need to necessarily know those drugs right now, maybe you've heard of them. And then succinylcholine intravenous is to bring on the profound paralysis. And I usually look at the patient when we've given succinylcholine because I'm waiting to see those little fasciculations everywhere, and I know that it's taking its effect, and shortly the person's going to be completely paralyzed when the fasciculations have stopped. Okay, so it binds to the acetylcholine receptor. Non-depolarizing agents, they don't depolarize the muscle at all. They don't have all those adverse effects with hyperkalemia. They don't have all those reasons to avoid giving them, such as in children and children with congenital muscle diseases and people with strokes, people with crush injuries, people with severe burns. They don't have all those reasons to avoid them. So they're popular for that reason. The downside is they last a bit longer. So if I give rocuronium and I want to intubate someone, if I have difficulty intubating someone, I can't get the endotracheal tube into the trachea, I'm looking at 20 or 30 minutes of bagging them or potentially bringing out the reversal agent for these non-depolarizing agents. And they do have a reversal agent. Succinylcholine doesn't. The non-depolarizing agents do. Okay, so how can we reverse these drugs that we see on the right-hand side here, rocuronium, vecuronium, or pancuronium? Okay, well, we could give something like neostigmine or pyridostigmine. And what are they going to do? Well, they're going to inhibit acetylcholinesterase. And now you're going to have more acetylcholine at the neuromuscular junction. and that's going to allow the acetylcholine to bind even better to overcome these drugs because you have more acetylcholine in the neuromuscular junction. Okay, so that's one way of reversing them. There's now actually a reversal agent that's come out that's used that actually binds these drugs and gets rid of them out of the neuromuscular junction, and it's called Sugamadex. Sugamadex. Okay. So you might come across this drug, or you may be asked, do these have a reversal agent? These do now, okay? Sugamadex. And what they do is they just bind directly onto these molecules, rocuronium or vecuronium or pancuronium, and they render them inactive. And then the neuromuscular junction can perform as normally with the acetylcholine. Okay, so I don't have anything to discuss on this slide. I'm just going to let you know I'll do this final painful review on the next slide. I know there's a lot of information. It'll take a couple of rounds through this to get comfortable with it, but it will start to make sense. And it's a very important module. Not every module is as important as others, but these autonomic nervous system modules are important to try and get a grasp and try to understand, because so many drugs have similar effects to them. So you really want to understand when someone says this has sympathomimetic effects, or this has anticholinergic effects. And of course, I've mentioned the types of receptors in the sympathetic system, and we've spoken about receptors in the parasympathetic system, which are significantly easier because really you just have acetylcholine and you have muscarinic receptors, right? Which are the receptors for the parasympathetic system. I'll carry on in the next slide just a bit more if you want to continue. Okay, so we're coming to the end of this module, the parasympathetic and the sympathetic system, the autonomic nervous system. And I mean, what I would suggest is take these four groups and go through in your mind, what are the side effects of a cholinergic agonist? What are the effects of a cholinergic agonist? Do the same for a cholinergic antagonist. Okay, so there's the parasympathetic side. And list the drugs. Okay, we did do some prototype drugs. Now, what about an adrenergic antagonist? So beta-1 blockers. They're adrenergic antagonists. Alpha-1 blockers. They're still adrenergic antagonists. What about the adrenergic agonists? Well, those would be things like epinephrine, norepinephrine, dopamine. So go through those and understand, okay, when I stimulate the adrenergic system, what effects do I get? What side effects do I get? So you should come up with a list of four sections. And study them and understand them, because after a while it'll really sink in and start to make sense on how this autonomic nervous system is so important and why the body does this, so that you don't have to do it on a conscious level. Okay, so this slide, another breakup of the two systems in the autonomic nervous system. Okay, so the sympathetic system can be upregulated. It can be turned on by adrenergic agonists. So they're going to be your epinephrine, norepinephrine, dobutamine, isoproterenol. So any sympathomimetic. If we're talking about illicit sympathomimetics, we'd be talking about something like cocaine. So cocaine turns on the sympathetic system, And that's why you get so many sympathetic symptoms with cocaine: tachycardia, sweaty, extremely high blood pressure. They can get heart attacks because of the high blood pressure and the tachycardia. So adrenergic agonists turn the system on. The only weird one in this group are the alpha-2 adrenergic agonists. Okay, so that's that clonidine and methyldopa that stimulates the brainstem, the alpha-2 receptors, and down-regulates, turns off norepinephrine secretion to the body. All the other ones, the beta-1 agonist, okay, that stimulates the heart. The beta-2 agonist, okay, that bronchodilates in the lungs. It also affects the uterus. It relaxes the uterus. A beta-2 agonist actually relaxes the uterus, okay? An alpha-1 agonist vasoconstricts. It tightens up the the arterioles, raises the blood pressure, okay? What about sympathetic system off type drugs? Adrenergic antagonists or blockers. So those are your beta-1 blockers for the heart, such as metoprolol, and many of the OLOLs are, all the beta blockers down-regulate the heart. So if they're selective, such as metoprolol, we call them cardioselective, since they decrease the heart rate, they decrease contractility, they decrease dromotropy. Okay, if they're non-selective, then they can be beta-1 blockers and beta-2 blockers. So that's where you get into trouble. You can get into problems with shortness of breath because you're blocking the beta-2s in the lungs, and potentially causing some wheezing and some shortness of breath. Okay, and we would avoid non-selective beta blockers in asthmatics and COPDers. We avoid beta blockers in diabetics because they don't sense the lowering of their blood pressure, since you're blocking the sympathetic nervous system. What about the parasympathetic system? Okay, cholinergic agonist. So something like neostigmine, physostigmine is increasing acetylcholine, right? And you're going to get cholinergic symptoms. So know all your cholinergic symptoms and side effects. And then anticholinergic, right? So you're turning off the parasympathetic. So you're going to have dry eyes, dry mouth. You're turning down the acetylcholine in the brain. So you're going to have confusion, delirium, if it's really, if the anticholinergic effect is really high. You're turning off the gastrointestinal tract, constipation, decreased bowel sounds, decreased secretions in the bowel. What happens to the bladder? You can cause urinary retention, inability to urinate because you're blocking the parasympathetic to the bladder. Okay, so just play around with these a bit. That I really think you'll get it over time. Okay, this is the last slide. I couldn't help myself, and I added this one. I think it just really brings all the effects of both the sympathetic and the parasympathetic together. And I think if you're able to understand each of these effects of what it does, then I think you have it. So so go through the sympathetic side on the left and see that you understand that the sympathetic system does all these things. And go through the parasympathetic and understand how that system works in a relatively opposite way to the sympathetic, and with its receptors. And I think if you're able to really have a good sense of feeling for this type of slide and work through the receptors of the sympathetic and the parasympathetic, I think you're well on your way to understanding and retaining some of this information. I won't go through each and every one of these. If you have any questions for me, I am on the Ameritech website or email. It's Karagesian, so G and then with a K, Karaguesian. You can send me an email through the Ameritech email, and I will respond to you. So I hope you enjoyed this module. I know it's a bit long, but it's an important module to understand.